Hi everyone, welcome to this week's episode of Guideline Review of the Week. So, this is a feature that a lot of thought process has gone into, and we have introduced this with the aim of sharing with you an in depth, but something that is done within a short span of time discussion of guidelines, bulletins, articles, and a lot more. The intention behind this segment is that a lot of residents being a majority of the students who are watching this, residents during the residency tend to be asking on what is the ideal protocol of management? What should I be informing my faculty regarding what would my plan be for the management of this patient? So this is exactly for y'all, and we'll be discussing cases that are often seen in the ward and also the ones that are not that often seen, but you would encounter them in your clinical practice. And we assure you that whatever we are sharing would be updated and would be from the best of resources available. So, the first episode in this segment is going to be for chickenpox in pregnancy. So, very recently, as recent as last week, I had this patient who presented to my emergency department. She was referred to us from a peripheral center in view of her having these rashes on her body. If you could see these rashes, these were classical rashes of chickenpox that she had, or what we also call as varicella zoster. Now, if you could see that these were her thigh rashes and these were on her calves, but on her abdomen, these rashes seem to have crusted. So it was a very classical chickenpox rash that she had, wherein we say that the rash in chickenpox comes in various phases across the entire body. So this patient not only had crusted but also had active vesicles on her body, which meant that she was active in her infective phase and would be infecting the baby as well as the treating doctors for her. So today we'll be discussing this from the Green Top Guideline by Royal College of Obstetricians and Gynecologists, which speaks on this very topic, that is chickenpox in pregnancy. I'll be briefing you all on how would we manage this patient and what would be the ideal management for such a patient if she were to present in your wards. First of all, what we did was we had a team of around 10 to 12 doctors in which we asked who are the ones who have either been vaccinated or the ones who have had chickenpox before. Fortunately, I was one of those who had chickenpox in my childhood, and hence I was one of those who had lifelong immunity to it. So, if you remember that you had read chickenpox in your microbiology lectures in virology, you had read that a single exposure to chickenpox is good enough to grant you a lifetime of immunity. Same goes with vaccination. Though vaccination is not that prevalent currently in India as it is in a few other countries, but the active infection with chickenpox at some point in life is one of the determining factors that we have to determine whether a patient is immune or not. So when a female is coming to me with this, let me assume that I have other patients who I do not know whether they had chickenpox or not. And this is something that we don't even ask much in our communities. But it is something that is recommended that you ask, wherein, if you can see this guideline over here, it mentions that a female should be asked prior to conception whether she is vaccinated, and if she is not vaccinated, then preconceptionally she should be vaccinated with varicella zoster vaccine. Why do I say preconceptionally? Because varicella zoster vaccine is a live attenuated kind of a vaccine which is eventually contraindicated in pregnancy. I can't be giving this in pregnancy, so she should either be vaccinated preconceptionally or postnatally. Postnatally, she can safely take this live attenuated vaccine without the risk of transmitting it during breastfeeding. So she should not worry about it. For the ones who have not been vaccinated, I would rather want to ask. It is recommended that you ask those women if they ever had a bout of chickenpox, an episode of chickenpox in their childhood. Often in countries like UK, they even consider doing sero testing from the blood that is collected at the first visit. But given that it's not a cost intensive thing, we do not practice it in our country. So, what if a patient has come to you? This patient who I showed you the picture of had come to me with active chickenpox lesions. There was not much that I could do about it. But what if a female comes to you that she has had significant exposure with chickenpox very recently? Now, what is significant exposure? The significant exposure is defined as if there has been a face-to-face contact with someone who actively has chickenpox, or if the person has been in a room for 15 minutes with a person who has chickenpox in the same room or in the same ward. This indicates a close contact. And by active infection, I intend to say the patient who has not started crusting. So it is recommended, or it is said that chickenpox is maximally infective 2 days prior to the appearance of rash, till the day the entire rashes have gone and now there is just crusting, that is scabs have formed all over her body. But what if a female has come and she is pregnant and she has contacted a person who actively has those vesicles on her body? So they recommend that we should be giving VZIG, that is varicella zoster immunoglobulin, has to be given within 10 days of the first contact. This is what RCOG says. Williams will say that you can even give it less than 4 days. In fact, they're recommended to give it less than 4 days or 96 hours after the first contact with an actively infected patient. So as you can see that this guideline recommends that it has to be given within 10 days of contact, because after 10 days, it would probably be impossible to prevent this patient from getting active infection. So the first thing that you need to do is, whenever a patient is coming to you with a history of being in contact with a patient having with a person having chickenpox, you ask her if she had chickenpox earlier, if she ever had it in the past, then be assured that she has been immunized. She doesn't need to receive VZIG. But if she tells you that she has neither been vaccinated earlier nor has she ever had chickenpox earlier in her life, you should be giving her VZIG. But even after giving VZIG, this female is now going to be infective. And by infective, I mean she'll be infective other people for at least 8 to 21 days if she's vaccinated within, I mean, if I'm able to give a VZIG within 10 days, she'll still be infecting other people for almost 20 days. Whereas if she did not receive a vaccine, she'll be infecting the people for almost until 28 days after the period of contact that she had. So ideally, it is always said that every tertiary hospital should have a VZIG available. If they do not have it, what we can also give is IVIG. It is a non-specific immunoglobulin that can be given intravenously to these patients. It is also recommended that these women should not be contacting anyone else for these days. Now, what if a female comes to me with an active rash, the way I had seen her? Now, this female had come to me 7 days after she had developed that rash. The female that we saw earlier in the picture, she had come to me after 6 days of having developed rash, which is also why she had started developing scabs over few of her vesicles, whereas few were yet to develop scabs. So, if she would have come to me, ideally within 24 hours, I would have given her acyclovir. Acyclovir is given before and after 20 weeks. The recent recommendations say that irrespective of the gestation, you should be giving her oral acyclovir if she's coming to you within 24 hours of developing rash herself. And this oral acyclovir has to be given in the dose of 800 mg for 5 times a day. And this has to be given for at least 7 days. So acyclovir has only gotten a role if the patient is going to be coming to me within the first 24 hours of getting a rash herself. But unfortunately, if this patient along with rash has also gotten severe symptoms, and by severe symptoms, I mean to say if she's getting respiratory symptoms, if she's getting respiratory symptoms if she's also getting central nervous symptoms like photophobia, seizures, if she's developing drowsiness, if she's coming to you in an altered state, in these patients, if you're seeing a classical rash of hemorrhage, if you see multiple petechiae on her body, or if she has any other comorbidities like she's a chronic smoker, she's someone who probably has COPD, in these women, oral acyclovir is not going to work. You have to be giving in these patients intravenous acyclovir. So intravenous acyclovir is indicated in patients with severe chickenpox, and by severe chickenpox I mean systemic chickenpox, not just the dermatological manifestation, but also the central nervous system, hematological, respiratory manifestation of this disease. What is this acyclovir going to do though? This acyclovir is going to help me prevent the transmission of chickenpox to the fetus. But unfortunately, if this happens, now this female had come to me at 38 weeks of gestation with chickenpox. It is said that if this female would have developed chickenpox before 28 weeks, the risk of transmission to the fetus would have been less than 1%. But now that she had come to me at term, and in fact, she had come to me in active labor, having an active infection, she had a risk of development, the baby had a risk of developing fetal varicella syndrome. In it, there is scarring of the skin, as you can see over here. This limb, this lower limb of this baby is scarred because of that chicken pox. Also, there is going to be dermatomal distribution. Basically, as you know, that this virus resides in one specific nerve of your body. So basically, it affects only those nerve roots wherein that nerve root is supplying. So that dermatological manifestation is always going to be there, especially when there is recurrence in adults. But in these babies, this skin's affection is going to be in dermatological or dermatomal distribution. Or dermatome is a place which one nerve root supplies. There are also going to be eye defects. There is going to be microphthalmia. There is going to be fibrosis in the eyes. Here you can see that this baby's eye also has been affected. There is going to be hypoplasia of the limbs because of this fibrosis, what we call as cicatrization. There is shortening of the limbs because of this dermal fibrosis that you can see over here. Also, there is going to be mental retardation because of the central nervous system affliction, and autonomic nervous system dysfunction is going to be there. Autonomic nervous system dysfunction is going to cause bowel and bladder abnormalities, and this baby will have a very poor prognosis. And even if it does survive, it will have a lot of deformities because of this disease that it has incurred. So, how do I diagnose if this baby has gotten this infection while it is still inside the uterus? What I can do is 4 weeks after the female has developed. Now, in this patient who had come to me at term, there was nothing I could have done. I just had to deliver the baby and I had to give it active vaccination as well as passive vaccination through VZIG. But if this pregnant female would have had this chickenpox in her first or second trimester, after 4 to 5 weeks, ideally after 5 weeks of infection, and I say 5 weeks because it takes 5 weeks for this virus to appear in the amniotic fluid. I'll be doing amniocentesis irrespective of the gestation, then just to do PCR, that is polymerase chain reaction test, to check for the DNA of varicella inside the amniotic fluid. This is if the mother had developed varicella or chickenpox in a first or second trimester. After that, I'll be testing the rates of false negatives are very high. Hence, even this is preferably not done. And if it is being done, you have to avoid doing it from a place if there is any active chickenpox lesion in that region. Now, what if the baby is delivered irrespective of this? Just like this female that I showed you, this baby is, by the way, not of that mother. This is just a picture that I've gotten to show you fetal varicella syndrome. Now, what if the baby is born to a mother who is having active infection? Now, they say that a female should ideally delay delivering a baby till 7 days after active infection. So, she should be delivering after 7 days and preferably after 4 weeks of the infection, because this is that time that will allow that female to develop antibodies, that is IgM first will be developed, following which IgG would be developed and the baby would then be protected. But if it is being delivered within 7 days, as was the case in my patient, this baby is at a very high risk of developing neonatal varicella, which will have very similar manifestations to the one that I showed you with fetal varicella. To prevent this, I'll be doing something that I similarly do with patients who have hepatitis B. I'll be giving this patient VZV, this baby VZV is active immunization after delivery, plus VZIG, that is varicella zoster immunoglobulin will be given to this baby after delivery. Again, if I do not have this, I can also give IVIG. I did not have this in my center. VZIG was not available as this patient was delivered late in the night. So we gave this baby IVIG through intravenous route. Hence, this female after her delivery We'll be checking her breasts. On the breast where there are no active lesions, there are crusts. She can feed from that breast to the baby. So breastfeeding is not contraindicated in these patients. It can be fed through a breast where there is no active lesion. So to summarize what we have spoken today, whenever a female is coming to me, if a pregnant female comes to me, if she has had a contact with someone with chickenpox, active chickenpox, then I'll be asking her about her history. If she gives me a positive history that she has developed chickenpox in the past, in these patients, I need not do anything. If she gives me a positive history, nothing to be done, nil, active management, nothing to be done. But if she gives me no positive history, as in no history of vaccination or active infection in the past, active infection, then this female will be given VZIG if she's coming to me under 10 days of her contact. If unfortunately the female comes to me, the pregnant female again now comes to me, pregnant female comes to me with active lesions, with active chicken pox. If she comes to me within 24 hours, I'll be giving her oral or IV acyclovir. It all depends on whether it is severe or not. Severe is basically systemic manifestations. The dose is 800 mg into 5 times per day into 7 days. Whereas if she's coming to me after 24 hours, there is nothing I can do. If she has developed active rash, VZIG is contraindicated. Do not give varicella zoster immunoglobulin if she has active lesions on her body. If she's coming to me after 24 hours, I'll just say, don't worry now. We can't do anything much about it. But what we'll do is, after 5 weeks, if the delivery has not yet occurred, we'll do an amniocentesis for PCR of varicella zoster virus to see if the baby has developed it. Plus, if the female is going to deliver, if she delivers within 7 days, in less than 7 days, then the baby is given VZIG plus varicella zoster vaccine. That is active immunization plus passive immunization is to be given to the baby after delivery. So that is it for today's episode of Guideline Review of the Week. We discussed chickenpox this week. We'll be discussing several more topics in the coming week. Do stay tuned with us. Do follow eConceptual and Conceptual OBGV, and you will be getting more such videos in coming weeks. Thank you. Please do let us know if you like this feature from us. Thank you.